Thank you, Dr. Amol. Thank you, Dr. Nikhil. I always thought ELCC stood for early lung cancer, unlike European lung cancer, because this is what I would want to deal with more and more. But anyways, jokes apart, thank you for giving me this opportunity to talk on this wonderful publication which came last year actually, segmentectomy versus wedge resection for stage 1 non-small cell lung cancer. It's a meta-analysis. And I'll take you through the publication, and in brief, I'll also talk about related papers, and Amol told me to talk about my practice, so we'll go about it. But just to give you an update about this publication, so this publication was published in the Journal of Surgical Research. Now, this journal is the official publication of the Association of Academic Surgery and the Society of Asian Academic Surgeons. I actually had not heard a lot about this journal, but when I reviewed the publication, I realized that this journal goes back to 1969. So it's really a good and long-standing journal. This is the right now is the 262nd volume in June 2021, and it carries an impact factor of 1.840. So when this paper was actually published, this had a greater impact factor of 2.5, but for some reason it has come down to 1.840, which just shows that it's an evolving field, and we need to be very careful about where we send our publication and where we pick up evidences from. Now, this was the lead authors were a surgeon, anesthetist, and a statistician, all from the second affiliated hospital of Air Force Medical University from Xi'an region of China. I highlight the date that it was received on the 31st of January, revised on the 11th of May 2019, and it was accepted on the 30th of May. It was made available online on the 2nd of July 2019. So you might feel that it's a 2-year publication, and why are we discussing this in 2021? So this is because the ELCC last year, which was to be held in Geneva, was cancelled due to COVID, and probably that is why it was presented this year in ELCC. And it shows that even if the publication goes it gets older, it does not lose its significance. It still remains in importance, and that is why we are talking about this year. Also, I also want to highlight that meta-analysis is more of a statistician-driven field, and the lead author again is a statistician in this. And the publications I'll show you subsequently also show that a lot of meta-analysis, especially for a rare for topics where you are not getting more and more of randomized trial, where the patient subgroups are less, more and more data is derived from meta-analysis, and such is the case with SBRT versus surgery for early lung cancer. So segmentectomy versus wedge resection is also something which is seeing more and more meta-analysis, and somehow more and more of them are coming from the China region of the world. So again, something that we need to look at. So what we know for surgery for early lung cancer, this is how the paper begins, creating a background that the standard of care for stage 1 lung cancer is lobectomy with a systematic mediastinal lymph node dissection, which now with over prolonging times have changed into a sublobar resections. People are now looking more and more at conservative procedures. We are looking at how we can offer better surgery to a larger group of people. The lobectomy was based on the lung cancer study group published in 1995. Since then, a lot of water has passed under the bridge. PET-CT has now become standard. We have better EBUS imaging. CT scans are much more precise, so there are lesser chances of missing out occult disease. So that is where probably sublobar resections are more and more coming up. But sublobar resections themselves could be a wedge resection versus a segmentectomy, and the burning question among surgeons who are offering sublobar resection is to go for a wedge resection versus segmentectomy. For non-surgeons in the group, just to say why there's a debate about wedge resection versus segmentectomy. Wedge resection is a non-anatomical surgery where you go in by VATS or by open technique, and you just take a wedge as the name suggests of the disease along with some margin. It's a more simpler, it's a more quicker procedure, and probably that is why it's being applied more and more in patients who are probably not fit for a lobectomy or have other significant comorbidities. But segmentectomy is a more technically more demanding procedure. You know, you are looking into not at the major, the primary bronchi and the secondary bronchi, but going beyond it into the tertiary bronchi. You are identifying those bronchus, you are identifying those vessels, and you are ligating them or stapling them individually, so that the segmentectomy becomes a little more demanding. So it might actually become that the procedure becomes longer than a lobectomy, and you need to have a greater surgical skills to do that. So what the paper did, that it looked into the 4 databases, that is Embrace, Medline, and PubMed, and it looked with the keywords segmentectomy, wedge resection, limited resection, or sublobar resection, along with lung cancer or NSCLC, and they found out 1905 publications. They removed some duplicates. They included studies if they were in English. They included stage 1 non-small cell lung cancer. They had segmentectomy or wedge resection, and their primary objective should have been should have OS, DFS, or cancer-specific survival as one of the endpoints. So that was important for the study. So they could narrow down into 19 studies. Of these 19 studies, 4 were prospective, whereas 15 were retrospective studies, and they combined, they had almost 14,000 patients. Of these, 3,600 patients were in the segmentectomy group, and 1,593 were in a wedge resection group. So I would actually say that it is a simple methodology where you pick up all the studies from multiple groups, but you need to have a very stringent criteria on how you are going to choose those studies, and this gets reflected in the heterogeneity, which we'll talk about in the next couple of slides, which represents the how strong your data is. So the 3 endpoints that they had reported were overall survival, the disease-free survival, and the cancer-specific survival. So the overall survival was reflected in 15 studies, which combined a total of 12,956 patients, and they had a hazard ratio of 0.82 in favor of segmentectomy, which was found to be significant. This is the forest plot for all the 15 studies, and you'll see that it's a fairly heterogeneous trial, with all of them bordering along the midline on the left side, along the line of unity. If you see, the I-square for this was 27%, which suggests, you know, mild heterogeneity. So fairly acceptable data. We'll compare it with the previous publications, and we'll realize that this is what the standard of care is. The other thing that they looked as were cancer-specific survival. They were good enough to define cancer-specific survival as, in the methodology, they defined it as from the time of diagnosis of cancer to death due to cancer, versus DFS, which was death due to any recurrence. DFS was defined as time of onset of diagnosis of disease to diagnosis of recurrence, versus cancer-specific survival was time of death due to cancer. So they defined cancer-specific versus DFS, and cancer-specific survival was reported in 7 studies, a total of 7,427 patients. Again, the hazard ratio was in favor of segmentectomy, with it being a significant p-value of 0.01. You find that actually in this data, the heterogeneity was almost 0%, and all the studies were overlapping with them, and the diamond that you see is at 0.71 in favor of segmentectomy. So again, this study collated the data and showed that the cancer-specific survival was better with segmentectomy as compared to wedge resections. The disease-free survival had a greater heterogeneity. 6 studies reported it, with a total of 1125 patients, and the hazard ratio in favor of segmentectomy was again 0.73. But if you look that the data on the forest plot actually had a greater heterogeneity, with the I-square being to the tune of 40%, but still The p-value came out to be significant with 0.04, and they concluded that the disease-free survival was better with segmentectomy as compared. So the discussion basically summarized these 3 points: that the OS is better with segmentectomy than Wedge, DFS is better as more anatomical resection, and better nodal clearance is expected from a segmentectomy. And the paper was actually kind enough to accept that they had couple of problems in their data, that they could not take into the margin status after wedge resections. They could not interpret the nodal yield, which would have a major impact on the recurrence rates. They were kind enough to accept that they had not taken the reason for sublobar resection into consideration. We'll talk about this later. So the 3 main publications that we existingly have, which are there for us to look at, is this meta-analysis again from China, which looked into 9 studies, 1121 patients, and they looked into wedge versus segmentectomy, and they realized that stages, lung cancer stage 1 segmentectomy was better than wedge, but for tumors which are less than 2 centimeter, that is stage 1A, there was actually no difference. Similarly, there's this another study from the Chinese region which looked at that could we compare sublobar versus lobar. So the earlier study was wedge versus segmentectomy, and this was sublobar versus lobar, and they had a gregarious data of 38,959 patients. What they did good was that they divided the patients into intentional sublobar resection, where the patient was fit for a lobectomy, but you offered segmentectomy because the patient was better for a sublobar resection, versus a compromised sublobar where the patient was not fit for lobectomy and the patients had no choice but to go for a sublobar resection. And they realized that there was actually no difference in OS, but for patients in which in the compromised group, the significance was much worse in the sublobar resection, which actually said that if you do surgery which was unplanned and not indicated, especially in the sublobar group, you will end up having much worse OS as compared to the lobectomy. So it summarizes that you should actually plan for a sublobar resection, and you should not choose a patient for sublobar just because they are not fit for a lobar resection. The third, again coming from the Chinese subcontinent, and it was published in October 2014. They looked at 42 patients, total 42 studies, total 22,000 patients, and looked into sublobar versus lobar resection, and they realized that lobar had better outcomes. So if I was to look into the SWOT analysis for this study, the strength was that it had fairly large number, 13 to 14,000 patients, good number. It strengthens the existing norms that we surgeons follow, that segmentectomy is better than a wedge resection. There is at the most no non-significant heterogeneity in all the groups. DFS had the maximum heterogeneity, but nothing else. The weakness were that mostly they were retrospective studies. Almost 12,000 patients were sublobar in nature. We do not know the intention between the sublobar resection, whether they were intentional or compromised. We don't know whether it was surgical margins, tumor stage, and lymph node status of any of these patients. Now, the opportunity which has been in front of surgeons for quite long is to do a strong randomized trial to compare sublobar versus segmentectomy. There are ongoing studies more from the Japanese continent, where they are looking into the JCOG 0802 and the 0804, where they are comparing segmentectomies versus wedge in a randomized fashion for tumors less than 3 centimeter. And we expect some results to be out in 2024, hopefully. With this, I would conclude my presentation, and hopefully in time for the next presentation. Thank you, Amol, and thank you, Dr. Nikhil.